We're ready to start with our next presenter. We have Laura Shane-McWhorter. She is a professor emeritus in the Department of Pharmacology at the University of Utah. She is a member of the Board of Directors of the American Association of Diabetes Educators. She works as a clinical pharmacist and an educator for CHC Inc., which are federally qualified community health centers. She also works with an interprofessional education team consisting of students from different disciplines to provide care for underserved patients at Midvale CBC Clinic. And finally, she teaches different classes at the College of Pharmacy. So if you could give her a warm welcome.
Okay, can you guys hear me back there? No? A little bit louder. Can you turn it up just a bit? Okay, all right. Well, okay, so we're getting on the way to being able to complete some of the afternoon sessions, and once again, you run the risk of falling asleep right now. So you need to be able to be energized and think about things that we can do. So it's a great pleasure to be here today, and I've had the privilege of sitting with some of my colleagues from the community health centers and talking about some of the things that we see on a daily basis. So how many of you deal with patients that have diabetes? So lots of you. How about pre-diabetes? All right. And so a lot of what we want to talk about today is distinguishing between pre-diabetes and diabetes, because we know that there are 30 million people who have diabetes, but there are over 80 million who have pre-diabetes in this country. And it's estimated that one day 40% of Americans will be diagnosed with diabetes unless they belong to one of the minority groups, which are fast becoming the majority groups, and that would be Hispanic patients, and that's half the patients who are Hispanic will develop diabetes. So my objectives for today are to be able to just look at what are the differences, the physiologic differences between diabetes and pre-diabetes, and then look at very simple suggestions that we can incorporate and use in our patients to really be able to decrease glucose, but at the same time improve their overall health. And then to be able to look at this need for individualization of treatment to really be able to make some strides in dealing with trying to help our patients achieve better overall health. So let's start out with an example. I have to do this because I'm a teacher, right? And so we always talk about case-based learning. So suppose you have TP, who is a 32-year-old male who is diagnosed with pre-diabetes, okay? So his glucose is 160 2 hours after he drank a smoothie at a very popular local juice bar. That almost serves like a glucola challenge in one of those smoothies. Okay, so his provider draws labs, including an A1C, and the A1C comes back at 6.1%. So he's referred to the health educator. Who are the health educators in this room? Really, all of us, okay? We're all health educators. And he's supposed to receive education about how to manage the prediabetes. So he wants to know, what is this prediabetes? And how does that actually differ from diabetes? And I can tell you that the word prediabetes is very, very interesting, because many patients now come in and they're saying, I think I have prediabetes, or my friend has prediabetes. Can you tell me, do I have prediabetes? And oftentimes, we get all of the labs done and they actually have diabetes already. So we're trying to prevent this from happening. So in looking at all of this, let's distinguish between prediabetes and diabetes, because really prediabetes is just this continuum of glucose and blood pressure values and also all of these other lab values. So prediabetes is a condition where the glucose level tends to be higher than normal, but yet it's not quite high enough for it to be considered diabetes. Diabetes, on the other hand, is a disease that's characterized by high blood glucose values that result because of the body's inability to produce or use insulin. Prediabetes, this is really an important concept. Not only does it place individuals at risk for type 2 diabetes, but it places them at risk for heart disease. So sometimes we even skip the diabetes part and go straight into the cardiovascular disease part of this whole continuum. And in diabetes, the hyperglycemia that occurs is actually associated with complications. And they could be short-term or they could be long-term complications. And this is something that I call the onerous opathies, things like the nephropathy and the retinopathy and the neuropathy, as well as macrovascular disease, which is cardiovascular disease. And that's going to be the strokes, that's going to be the heart attacks, the MIs, and peripheral vascular disease, and all kinds of other manifestations. So the one thing we do know, however, is that healthy interventions are going to help prevent the progression to diabetes. That's going to be a very, very important thing. So the previous speaker talked about motivational interviewing, and I think it's really critical to try and learn as much as you can about this, because that's going to be a key element in terms of dealing with your patients that have prediabetes to try and prevent that progression that may occur. So then you may be wondering, okay, well, diabetes, okay, and you all know that there's type 1 and type 2 diabetes, and that there is also gestational diabetes. And some people are even talking about diabetes type 1.5, where you can't really distinguish between type 1 and type 2, but they have some components of both. But nevertheless, it's really important to try and assess those patients and look at type 1 and type 2. So type 1, we used to always say, well, the diagnosis occurred in early ages, but that's not really true anymore. We know that people could be middle-aged or even elderly and all of a sudden be diagnosed with type 1 diabetes. We do know that there does tend to be an abrupt onset, whereas with type 2 diabetes, it's very insidious, and so a lot of patients will say, but I feel just fine. I don't understand why you've diagnosed me with this, because I feel just fine. If I was ill, would I not feel some symptoms? And the thing is, that may be true at times, certainly when they're first diagnosed, but it can be very, very insidious. So we do know that there is a genetic basis for both. We used to think that there was a stronger genetic basis for type 2 diabetes, but that's not really the case anymore. But we do know that with type 1 diabetes, there's really almost no insulin production, whereas with type 2 diabetes, when it's diagnosed, maybe 50 to 60% of the beta cells in the pancreas no longer are producing insulin. And that decline in function continues even after the diagnosis. And it's a slow decline, but it's something that when a person is diagnosed, we're trying to arrest or slow down that particular process. We know that in type 1, ketoacidosis is common, whereas in type 2, sometimes it's more of a hyperglycemic, hyperosmolar state that may be occurring. And in type 1, it's an autoimmune process, whereas with type 2, we know that it's insulin resistance and possibly obesity that may be related to this. In type 1, there's initially no microvascular complications, but in type 2, one of the things we know is that the patient may have had diabetes for several years, so that when the diagnosis is made, they possibly already have complications. So that's why, for instance, with a type 1 patient, we don't really right away send them to the ophthalmologist for an exam, but we will send a type 2 patient because they've had probable long-standing diabetes for some time. And the other thing we know is that the difference between type 1 and type 2 is that initially any kind of macrovascular complications or complications that involve, for instance, the heart, that's rare. Whereas often with type 2, sometimes the presenting form of diabetes in a type 2 individual is having a stroke or an MI. So it can be very, very insidious. And then, of course, GDM, gestational diabetes. This is something that occurs during pregnancy. But what's interesting about hyperglycemia during pregnancy is that if the diagnosis of hyperglycemia is made, that initial diagnosis in the first trimester, it's probably type 2 diabetes. Whereas if it's in the second or third trimester, then that is gestational diabetes, and that predisposes that woman to a risk of type 2 diabetes later on. So 50 to 60% of women with gestational diabetes will go on to progress to type 2 diabetes. So often when I'm talking to a woman with diabetes, I will ask her whether or not she had hyperglycemia during pregnancy. I'll ask her about what was the birth weight of her children. And importantly, I'll ask her whether or not she was treated with insulin or not. Because women who have been treated with insulin during pregnancy are probably at greater risk for then having to use insulin later on. Not almost exclusively, but they're more prone to having to do this. Okay, so this is an important slide. This is probably the most important slide here. So I'm going to walk you through this. This is adapted from the CDC that can help you determine whether or not a person is at risk for prediabetes. So if you look at this, first look on the right-hand side. Okay, find whatever your height is over here and look at the weight, okay? And look at that and see if your weight is at least that or more, okay? Because that's going to be one of the things that we're going to look at. Now look on the left-hand side, okay? And see whether or not you answer this yes or no. So first question, did you give birth to a baby that weighed more than 9 pounds, yes or no? Do you have a sister or brother with diabetes, with type 2 diabetes, or a parent with type 2 diabetes? And then here's the question about the height and the weight. And if your weight is the same or more than that listed for that height, you have to give yourself 5 points for that, okay? Are you younger than 65 and get little or no exercise in a typical day? Okay, if the answer to that is yes, then that's 5 points. Otherwise, no is 0. Are you between 45 and 64? Now start noticing this age-related trend in development of diabetes. So if you are in that age range, that's 5 points. Now look at this one, the very last one. Are you 65 or older? Because then you get 9 points. So how do you score this? Well, you add this all up. If your score is 9 or greater, you are at risk for prediabetes, okay, or for diabetes. If your score is 8 or lower, then you have a lower risk. But do you see what happens as we get older? That risk just automatically increases, so that virtually everyone who is 65 and older actually is already at risk. And what's interesting is that we're diagnosing more and more cases in people as they grow older, okay? So does this make sense? Okay. All right. So who should be tested? So this is per the 2018 guidelines that are published every January in the supplement to the journal Diabetes Care, which is the official journal of the American Diabetes Association. So people should be tested, for instance, if they're overweight, and that means a BMI that's 25 or greater. But if you're Asian, then that means you use a lower BMI, a BMI of 23 or greater, okay, if you're Asian, okay? And then one or more of those risk factors, having a first-degree relative like a sibling or a parent, if you're a member of a high-risk ethnic population, and that might be Pacific Islanders, it might be Asians, it might be Native Americans, it might be Hispanics, okay? And then someone who already has a history of cardiovascular disease, someone who has hypertension. And you know, it's interesting because in listening to Dr. Stoltz's talk this morning, the American Diabetes Association still lists hypertension as 140/90, whereas a few years ago it was greater than 130/80. And I can tell you, having been around for such a very long time, the pendulum swings in terms of guidelines and what is considered the cutoff value. I would say greater than 130/80. That's what I would agree with him totally. Or if they have a low HDL, that means the good cholesterol. If the good cholesterol is low, or if the triglycerides are higher, and you may wonder, why the high triglycerides? Well, if those triglycerides are high, that means that that's related to the fat in your body, and the triglycerides, when high, can damage the pancreas. That's why. And guess what organ produces insulin? The pancreas. Okay. So if a woman has PCOS, polycystic ovary syndrome, okay, that might be a risk factor for this. So this might be women, for instance, who are a bit heavier or who have a little bit of abnormal hair growth, for instance, on the face, or acne, or a person who's physically inactive, or conditions that are associated with insulin resistance, such as obesity and acanthosis nigricans. Okay, acanthosis nigricans, there's a picture right there on the bottom right. Can you see that darkness around the neck? All you have to do in your clinic is look around and see how many people you see that in. And see how many people you see who have that, who are children, okay, or adolescents. But that's a sign of insulin resistance. Or an A1C that's higher than 5.7%, or they have impaired glucose tolerance, okay, or impaired fasting glucose. So impaired glucose tolerance means that their glucose after a glucola challenge is between 140 to 199. So our patient who'd had that smoothie, okay, and he had a glucose of 160, There it is. You don't have to do a blood draw or do a glucolol. All you have to do is give them a smoothie from a local smoothie place and know that that would probably be positive. Impaired fasting glucose is a little bit more subtle. So that means a fasting glucose between 100 and 125. And most of us in clinic, if we saw a number like that, we'd say, oh, that's fine. That's okay. But it's really not, okay? And then if they've delivered a large baby, greater than 9 pounds, or they have a history of gestational diabetes, and this testing, per the American Diabetes Association, should start in everyone starting at age 45. And if it's negative, then check it every 3 years. But if they find pre-diabetes, then they should be tested every year to see if they cross the line. Okay, so in terms of testing kids, well, here's some of the criteria that you can see, and it's basically kids that are overweight or their moms had diabetes when they were pregnant with them, or their family members have type 2 diabetes, or again, looking at being a member of a group of people that are more highly prone to diabetes. Or they have the insulin resistance, and that would be that acanthosis nigricans. Okay, so why is prediabetes important? Well, the CDC has made a big point of developing all of these prevention programs. So how many of you are associated with the prevention program? Okay, a lot of people. So it's through our state health department, right? And there's a lot of people that are involved with that. So it's important because that person is at higher risk for developing type 2 diabetes, but not just the diabetes, it's the heart disease and the stroke, okay? And then the other thing is that those folks should be tested every year for diabetes, and the treatment for prediabetes is going to be lifestyle. So one other important thing, even if a person doesn't yet have diabetes, if they have prediabetes, we have to treat their cardiovascular disease risk factors. So that means if they have hypertension or if they have high cholesterol, we should be assessing that also and treating that as well, even if they don't yet have diabetes. Okay, so this just gives a side-by-side comparison of the difference between prediabetes on the left and diabetes on the right-hand side. And so there again, you look at the fasting glucose and the 2-hour plasma glucose. The A1C is a good measure as long as it's done by a lab draw, a venous plasma draw, okay? The point of care testing that we often use in clinic, that doesn't count. It has to be one done in the lab by whoever your lab source is, because they use the national standards for glycohemoglobin testing. And then the other thing we know is that for prediabetes, that risk is continuous. So it's just a continuum. For diabetes, if a patient comes in and they have just a random plasma glucose of 200 or higher, plus a lot of the classic symptoms of hyperglycemia, and that means they're really thirsty, they're going to the bathroom and urinating a lot, they're very hungry. Those are the 3 Ps: polyuria, polyphagia, polydipsia. So those are the 3 Ps, okay? So, and I can tell you that this is really interesting, and sometimes in clinic we have, for instance, males don't often come in for wellness checks unless something is wrong with their private parts. And when that occurs, one of the things that we might do is do a finger stick, and guess what? Lots of times we'll have that plasma glucose, just that finger stick of 400, and it's like, okay, all right. And then we'll do a venous plasma draw at the same time and know that that's what the situation is. Okay. So the CDC really has jumped on the bandwagon for the diabetes prevention program. But this actually has its origins many, many years ago in the diabetes prevention program study that involved a group of over 3,000 individuals who were at risk for diabetes. So they were all fluffy, as my friend Virginia says. They were fluffy, so they had a higher BMI. And the other thing is that more than half of them came from an ethnic minority. And they actually had different arms to this study. They had one arm that involved lifestyle, which was healthy food, physical activity, and doing a lot of visits to the dietitian and the physical therapist to do all of this lifestyle coaching. So that was one arm, and it was called lifestyle. They also had another arm that was metformin. Okay, we all know and love metformin, right? And then another arm was troglycerol, Resulin, which got taken off the market because of liver toxicity. And the final arm was placebo. And what they found was they stopped this program early because they had such great results from lifestyle that they wanted to share the results. And that first DPP program was published in 2002. But not only did they do this, they continued to follow those patients for 10 years, and now we have 15 years worth of data. So if you look at the left-hand side, lifestyle is in green, so green for go, right? Okay, and then metformin, the metformin group is in purple. So what they found was that with lifestyle on the far left, there was a 58% reduction in crossing the line from prediabetes into diabetes. With metformin, it was only 31%, but it was still okay. Then after 10 years, there in the middle, what they found, those same individuals, 34% sustained decrease in crossing the line to diabetes in the lifestyle group. For the metformin group, 17%. And finally, 3 years ago, the 15-year study was published, and they found that for lifestyle, it was still 27% decreased risk, and then 18% decreased risk with metformin. Okay, so that is a very, very important message that tells us all the most effective intervention is going to be lifestyle. Okay, so in terms of lifestyle, this is what they did in the DPP, the Diabetes Prevention Program. So what they did was they got people to lose weight, on average 7% of body weight, and they got regular physical activity to the tune of about 150 minutes a week. They also had recommended other things, like no matter what, we want people to stop using tobacco. And I like the tip about the number of times people are asked to stop using tobacco, because if we don't ask, then that's one less opportunity to promote that bit of wellness. Okay, to also have cholesterol and blood pressure checked every year. And in some cases, if lifestyle is not doing the trick, then possibly considering medications. And we're going to talk a bit more about that in just a bit. Okay, so key considerations. One of the things that lifestyle involves is self-management education. Because remember, the most important member of that whole team is the patient, okay? And 99% of all of the treatment for diabetes or prediabetes is done by the patient, just with suggestions by other healthcare providers. So we need to try and be able to find ways to motivate that patient to do some of those interventions. So one of the things then we know is that that patient has to be imparted with the knowledge and the skills and the ability that's necessary to really be able to take good care of themselves. It should be ongoing, not just a one-time. And many patients will say, oh yeah, I already went in for education. Okay, it needs to be ongoing. It needs to be patient-centered care. It needs to be shared decision-making, because remember, that patient is in the driver's seat. And we also need to address something called diabetes-related distress, which is different than depression. It's more the distress that all of this causes a patient and causes them to lack sleep. It causes them to have their blood pressure go up. It causes them to have a great deal of unnecessary stress in their lives. So what should a health educator do? Well, the very first thing we need to do is to offer a menu of survival skills, okay? And the areas to cover would be such things as what to eat, physical activity, when to follow up, how to monitor, if necessary, medications. And of all those questions, guess which one patients ask most of all? 99% of patients ask what? What can I eat? It's a very basic human need. 99%. That is what people will ask. And I'll never forget this poor little guy that I had in clinic that had been diagnosed, and it was 3 days before I was able to provide health education. And this poor guy had been eating salad straight for 3 days and drinking only water and eating salad, because he said that's the only thing he knew that he could probably eat safely. Okay, so we have to really think about all of the different things that we need to do to help empower our patients to be able to make healthy choices. And there's a lot more than that they can eat besides just salad. Okay, so the key components, healthy nutrition, and what does this really mean? So here's a disclaimer for you. I am not a dietitian. I am not a nutritionist, even though my patients in the clinic call me la nutróloga. Okay, I'm a pharmacist. But in hanging around with dietitians and in being able to become a certified diabetes educator, I've spent a lot of time following, shadowing dietitians and learning and reading about healthy nutrition. And it's something that we all can do. Okay, so one of the things that I learned from dietitians was, first of all, to assess what patients are doing. And you just do a 24-hour food recall, and I'll show you how to do that in just a bit. And then the second part of that is to do a food preferences history. So how many of you are dietitians here? Okay, so I've learned from you. Okay, so then going on with this, with the 24-hour food recall, you really just basically ask a patient everything they've eaten in the last 24 hours. And I know that in some clinics that patients are asked to fill out a 3-day food diary, which patients don't always do. You know, it'll look like this. It might say cereal, meatloaf, salad, you know, but you don't really know. So you have to probably just sit down with them and ask them, okay, what did you eat for breakfast and how much of everything? Like how, you know, what kind of cereal, how much? And use your hands with all of the things that we've been taught to do. Here we go, here's 1 cup, a fistful, okay? And what did you eat between breakfast and lunch and how much? What did you eat for lunch and once again, how much? How about between lunch and dinner? How much? How about dinner? How much? What did you eat after dinner? How much? And then once they start really thinking about all of that, and I tell patients, you may not really be able to remember everything, but we're really trying to plant a seed to help them try and become cognizant of how much they're eating and when, to try and avoid mindless eating, okay, to be more mindful of the times that they're eating and when. And the other thing too that I have learned so much from patients through the years, and I've heard patients tell me, no, I don't eat dinner. Okay, so I finally learned to ask, tell me what you eat in the evening. Oh, well, I might have some cereal and some milk and some fruit and some bread and some juice, but I didn't eat dinner. Okay, that's lots of carbs right there. Okay, or kind of the same thing for breakfast. Okay, and then the food preferences history. So how many days per, how many times a day or days per week do you eat the following? Things like a green salad, and what kind of dressing do you put on it? Veggies, and which ones and how much? Fruits, which one, how much? Is it fruit juice? Bread, is it white or wheat bread? How many tortillas do you eat a day? Sodas, are they regular or diet? Or is it Gatorade, or is it horchata? How about water? How much water are you drinking? And what about milk or dairy products? And what type? And what about yogurt? And that's a good time to make an intervention, because I find a lot of patients say, no, I can't drink anything with milk in it. It makes me sick. But that's a good time to make an intervention, to possibly recommend something like calcium plus vitamin D. Okay, and then protein. How many days do you eat chicken or beef or fish or pork or cheese or whatever? And I'll tell you a story about one of my patients. One of my patients was telling me that they didn't eat red meat. They were avoiding red meat. And I said, okay. So, and he kept going on, coming back to, I'm avoided red meat. And kept coming back to that, kept coming back to that. And finally I asked, well, tell me why this is so important about avoiding the red meat. And he said, well, you have to avoid red meat by making sure that you cook it thoroughly. And so what he was really saying was rare meat. And so he thought that when people talk about red meat, that they talk about rareness. Okay. And then even things like, what cooking oil do you use? Okay, and I'll tell you another story. People tell me, I didn't understand what the correlation was when people were telling me that they really toasted their bread or they toasted their tortillas. So again, you have to talk to your patients. Tell me why you think this is beneficial. Well, if you toast it, you burn off the carbohydrates. Okay, so, you know, even how people prepare this, and I know our dietitian in the room will also tell you that in terms of even grilling foods, there's some correlation between eating a lot of charcoal grilled foods and the development of advanced glycation end products, and those are complications of diabetes. And so the nutrition literature is now starting to emerge with some of those thoughts that maybe to avoid that, avoid cooking your meals at very high temperatures and maybe marinating them in something and slowly cooking them to avoid the formation of some of those advanced glycation end products. So even how we cook foods may become an important issue. But then in the food preferences history, how many times a week do you eat chips or sweets? And I can tell you, again, learning from my beloved patients, I'll never forget when I kept having patients telling me that what they ate for breakfast was un pan, okay, one bread. So finally, again, what does that mean? Was it a slice of wheat bread or wheat toast? No, pan dulce. Okay, pan dulce, great Mexican pastry. Okay. So, and then even cereal, and how much? Because people believe that you can eat lots and lots of cereal, and you really can't. So remember, there's no one-size-fits-all eating pattern, and it has to be individualized, and it has to be collaborative. But that patient has got to be in the driver's seat, being willing to make changes. Okay, so the goals are to really be able to promote and support healthy eating patterns, trying to support a variety of nutrients, and to achieve and maintain body weight goals, and looking at their individualized glucose and blood pressure and cholesterol goals, delay and prevent complications. That's what it's really about. And then But look at their individual needs, and we have to listen to patients about their personal and cultural preferences, their health literacy and access to healthy foods, because sometimes food insecurity is a very, very important factor with all of this. And then their willingness and their ability to make behavioral changes, hence the motivational interviewing, and looking at the barriers to change, but also to be able to maintain that pleasure of eating by providing non-judgmental messages. That's very, very critical. And to look at tools that are practical in looking at eating patterns rather than focusing on individual types of macronutrients or micronutrients or single foods. So for prediabetes, definitely individualized medical nutrition therapy. Patients should receive that ongoing treatment. And the other thing too is if they're overweight or obese, weight loss helps to decrease insulin resistance. So losing weight by eating 500 to 750 calories per day less. For women, here's just a generalization. It may vary, but for women, maybe in the range of 1,200 to 1,500 calories a day. For men, 1,500 to 1,800. Remember that if a woman is pregnant, they need more calories, okay? Or if they're breastfeeding. And how should this be done in prediabetes? Well, one way is calorie restriction, but look at the quality rather than the amount of fats consumed. And so if you follow things like the Mediterranean diet, that's high in monounsaturated fats, so things like olive oil, things like avocados, which is very healthy, or the DASH diet, nuts and berries, yogurt. Believe it or not, even a little coffee or tea may be associated with preventing diabetes. Now, I'm not suggesting that you start going to Starbucks and drinking lots and lots of Starbucks. Red meats and sugar-sweetened beverages are associated with an increased risk. So I had a pharmacy student, and he used to drink 3 regular Cokes every day. And he decided to stop drinking those 3 regular Cokes every day. And after 6 months, he had lost 40 pounds. And that was the only thing different that he did. And he substituted that, not with Diet Coke, but with water, which is the universal recommended beverage. Okay. So our goals, because of the diabetes prevention program, or a weight loss goal of 7%, lose about 1 to 2 pounds a week. That's what's usually suggested. Eat more fiber and whole grains. Limit and avoid sugar-sweetened beverages. So that means the regular soda. That means also the juice, the regular juice. The fruits, natural fruits are better because they have a lot of fiber. Try and limit the sodium for the blood pressure, and then evaluate for prediabetes every year. So some of the overall best plans, according to some of the literature, are going to be the Mediterranean-style diet, which is going to be veggies and some whole grain breads. Okay, certainly fruits and beans and nuts and seeds. Olive oil, low dairy, if possible, low red meats. The DASH diet, the dietary approaches to stop hypertension. Even in pregnancies, the DASH diet has actually been a good thing. And plant-based, or you can do low carb, lower carb, and focus on the carbs, the healthy carbs that are in veggies. And lower fat, looking at the type of fat and limiting sodium. Now, what about alcohol? Okay, so alcohol becomes an issue more when you have diabetes and you are on either insulin or secretagogues. Those are things like sulfonylureas. So what we tell patients with diabetes, if they choose to drink alcohol, is never to consume it without food, never fasting. And it may increase their risk, not only for more calories, but actually for hypoglycemia. Drinking alcohol acutely prevents the release of glucose from the liver. So if they're going to choose to drink alcohol, they need to be eating a little bit, otherwise they run that risk of hypoglycemia. Okay, and the other thing would be small amounts at one sitting, and 1 to 2 times a week is preferable to every day. And those are some of the quantities that are actually suggested in the literature. Women, less amounts than men, because actually estrogens that women produce inhibit the metabolism of alcohol. So alcohol hangs around a lot longer, and you have a lot higher levels in women. Also, to drink slowly. Don't just guzzle it down. Avoid the sugar-containing drinks and mixes, and be alert for hidden sources of alcohol, such as in over-the-counter medications, like cough syrups, for instance. Okay, so all of you have seen the plate method, and there are so many variations of the plate method. One of the important things to do, and the American Diabetes Association now has some really great resources, and they have a picture, a photo of the ideal plate, and they actually have the actual size. It's a 9-inch plate, okay? It's not a huge plate, it's 9 inches is what it is. And you can see that half of it is veggies, and a fourth is the carb, and a fourth is the protein. And other varieties, you can see variations of this as well. And I think it's important that patients know that if they try and follow this, whether it's for breakfast or lunch or dinner, that they're approximating the types of nutrients that they should be eating throughout the day. Okay. The very first step, if you're thinking about diabetes or even pre-diabetes, is to figure out what foods are going to make the glucose go up. So that's going to be basically carbs. It doesn't mean you can't eat carbs, but you have to be very, very conscious of what is the serving size. And people are often very dismayed to find out that the serving sizes might be very tiny. For instance, a serving size of rice is 1/3 of a cup of cooked rice. How impossible is that? Okay, pretty impossible. But then on the other hand, if they want to go with 3 servings and that's their carbs for that meal, 3 of their 4 carbs, okay. It's just about learning to make choices. And then also 1 tortilla or 1 slice of bread. And now I saw some tortillas the other day with net carbs, which I think is wrong. And they say the net carbs, 3 grams of carbs. That's wrong, okay? Because what they do is those tortillas have something like 12 grams of fiber, and supposedly you can deduct that, but you can't really. And we used to say, deduct the fiber, but the amount of fiber divided by half, and then deduct that. But now the newer trends in nutrition are saying, no, that's really not what we think. But there's a lot of marketing that is somewhat erroneous for patients. And the 2 words that patients will use are natural and organic. Those are the 2 magic words right now. Okay, so this just gives you an idea of what some of the serving sizes are. And people are often surprised by how little sometimes it is, but remember, you can eat lots of salad, you can eat veggies, okay? And so there's a lot of different choices that you can eat. Okay, so for a healthy diet, it's foods that are high in fiber, veggies, fruits, wheat bread, oatmeal, cereal, quinoa. Quinoa is great. That's a very trendy food right now. And that is something that is going to give people a lot of fiber as well, and it's pretty delicious too. Foods that are low in fat and salt, so less cheese if possible, less butter and cream or sour cream or mayo, less fried foods, less fast foods, okay? And that's probably one of the things that is hardest for everyone, not only in this room but around the world. And trying to cook meals in the oven, okay, rather than just breading them and frying them, okay? So, and teaching our patients how to read food labels. So how many of you have done this? Taught your patients to read a food label? Okay, all right. So the very first thing, the most important thing, is to teach your patients to see what is a serving size, because it can be very misleading. They may think that, for instance, a container is like a big container of some sort of beverage, that it's the whole container, but it may be 3 servings in there. The other thing is, here's just some choices for a 2,000 calorie a day diet where you can see the proportion of the different food groups. Then also another sample plan. This is one that I've written out. It's not evidence-based, but I just tell patients, well, try and at least do this. Eat 1 green salad. Eat 2 cups of veggies every day. Eat 3 fruits, but avoid juice. Try and have 1 cup a day of dairy, grains, some protein, and just try and do some of these things. Then the other thing too is that, again, looking at lots and lots of water and looking at all of the different menu options and healthy plate options, and showing them to your patients and have them choose one that they think that they can do and comply with. Then exercise. Here's some important things. First, ask what a patient's occupation is and how much physical activity are they really currently engaged in. How much screen time, whether it's computers or Facebook time or texting, or as well as television, and how to start. And you start with easier activities and choose enjoyable activities. I heard about a patient that what she liked to do, this is really way out there, but they let her do it in her hospital room, and that was tap dancing. Okay, and so they let her tap dance in the hospital room just because that was one thing that she liked. Okay, and then schedule the exercise, set goals and rewards, but don't have those rewards be food, okay? It might be shopping for something, shopping for a new lipstick, or trying to go to a movie, or something like that. Consider seasonal variations, because how many times have our patients say, well, I walk when the weather is nice, I walk, and it's like, okay, look at where we live, okay? How many months of the year can you really do that outside? So think about things you can do indoors. And then have a plan B, and pick a buddy to go with you. And so you want moderate intensity physical activity just to fulfill the DPP plans, 150 minutes a week. Break up that sedentary time, so, you know, just a little bit, you guys are going to get up and move around a little bit. And the CDC has actually begun to certify electronic and mobile health-based modalities, like as in apps, to fulfill what would be the equivalent of the diabetes prevention program. And so you need to evaluate that patient. Figure out, can they feel on their feet if they have diabetes? Because if they can't feel, they shouldn't be out there running. And avoid jarring exercises if they have retinopathy. And if they have very high glucose or high ketones, they shouldn't be exercising then either. How much exercise? 150 minutes per week, and try and achieve 50 to 70% of the max heart rate. So how do you figure your max heart rate? What you do is you take 220 and you subtract that patient's age. So 220 minus, say they're 40 years old. What is that? 220 minus 40 is 180. Okay, so that's our maximal heart rate, but we're doing just 50 to 75% of that. Spread it out over at least 3 days a week, or 75 minutes a week of vigorous activity, 2 to 3 sessions a week. Interrupt their prolonged sitting time every 30 minutes. Get up, okay? And then the other thing for older adults, Flexibility training. So for someone old like me, balance exercise. Can you stand on one foot? And how long? Yoga, Tai Chi, that sort of thing. Balance becomes very important as people grow older because we want to avoid falls. Okay. These are the meds that have been used to prevent diabetes, but metformin should only be used if the BMI is 35 or higher, in a woman who had a history of gestational diabetes, or if they're younger than 60. But okay, if we have to, we do use it. But in older people, monitor those B12 levels because B12 can go down. Other things that have been used are listed there. Even the fancy GLP-1 inhibitors or analogs like Victoza. So now TP has actually progressed from prediabetes to diabetes. And he goes in, and in his 15-minute appointment, his doctor says, okay, I'm going to start you on this medicine, but it might give you a stomach ache. And I want you to lose 15 pounds and eat fewer carbs. I want you to start exercising 30 minutes a day. I want you to check your sugar 2 to 4 times a day. Make an appointment with the ophthalmologist. Come back for other tests for kidney function and fasting lipids. Okay. So I know we're out of time, but we have to look at trying to understand things from that patient's point of view and see what they're wanting and willing to do and what they understand, and 1 to 2 goals at a time. Okay, so I'm going to just go through these really fast. These are things to consider, not just glucose, but blood pressure and cholesterol. Give that patient a menu of options of things needed for survival skills. So, and with medications, ask that patient each time, what are you taking? Because if you ask, are you taking your medications? Guess what they're going to say? Yes, okay. Well, are you taking your metformin and your glipizide and your insulin and your lisinopril and your HC? Okay, so you get the message. And teach patients to use the Ask Me 3 questions. What is my main problem? What do I need to do? And why is it important for me to do this? And use teach-back methods to make and put the onus on yourself. Okay, so Mr. Smith, to make sure that I explain this appropriately, tell me the things you're going to do, okay? And then review this each time a patient is seen and provide reassurance and support. Okay, these are the times when a patient should be referred for education, not just one time, and that's it, forever. It's a diagnosis once a year to review everything. Whenever there's new factors that influence self-management, and during transitions of care. So that is my presentation, and now you guys need to break that interrupted or uninterrupted period of sitting. So stand up, move around, walk around, and have fun.